Thank you. I am Terrence Muhammad. Thank you for joining us to hear about the Greensboro Health Disparities Collaborative. And again, I am Terrence Muhammad here with my collaborative member, Patrick McCarter. And he will be speaking a little bit later on this wonderful organization that we're going to share some of the history and the things that we're working on. So let's go right into it. So as you can see, the Greensboro Health Disparities is a mix of a lot of different people and from a lot of different backgrounds. But one of the things that we're about is trying to establish structures and process that respond to empower and facilitate communities in defining and resolving issues related to disparities in health. And all that means is that we came together and we have created this sense of family where there's doctors, there's medical people from the medical institution, from academics, and from the community and the advocates and researchers that are all coming together as one unit called the Collaborative to actually address health disparities. So how did we begin? We began in, really, we would say 2003, but I want to go back to 1993, and there was an organization called the Project Greensboro doing some work in the community and addressing different injustices in our Greensboro city. And then later in 1997, it formed the Partnership Project. And one of the main people around this part is Nettie Cole, who we love and who passed away in 2012 from cancer. But she was the spearhead of this powerful organization called the Collaborative, and she pushed the community, and she brought the People's Institute out of New Orleans for Survival and Beyond, for the People's Institute for Survival and Beyond, to bring around this Undoing Racism training to talk about systemic racism. And then in 2003, we started to form what we know now as the Greensboro Health Disparities Collaborative. And this all began because of a conversation around the Institute of Medicine report in 2002. So building the collaborative, we started September to December in 2003, organizing different people, as I said earlier, in the community, community advocates, people from the medical institution, people from academics, advocates, preachers, and we just had a bunch of culture sharing. And from that culture sharing, we wanted to work out how we want to do something and how we want to address health disparities. And we did a lot of culture sharing and building before 2004, where we actually had our first meeting and we had an Undoing Racism workshop to kind of get us all on the same page. And we developed a full value contract between us and how, and a common language that we work together. So continuing the construction, we made sure that we understood internalized racial oppression and superiority in the healthcare and the healthcare institution. And we had these focus groups that had these discussions around Undoing Racism workshops. And then we developed the community-based participatory research, where all of us got trained on how to do this and how to really engage around the community. And the community was the basis of the collaborative. And as I said earlier, we developed a full value contract, and we developed grant writing subgroups to learn how to, as all of us can work on how to work on this NIH grant to do this work that we have started. So before Patrick comes up, just want to once again reiterate that the 2002 Institute of Medicine is the basis of our work that showed unequal treatment. And we wanted to make sure that we can eliminate and really first show that there is health disparities in particularly the area of breast cancer between Black and white women, but then also later in our work, trying to find a way to eliminate these disparities. And this was done through the collaborative. Right now, we're going to turn it over to my collaborative member, Patrick McCarter, and he's going to give you the two particular works, Seek Cares and A Cure, and talk about those actual works that we have done to help around these areas of health disparities. Patrick?
All right, thank you, TC. So I'm Patrick McCarter. I'm a member of the Greensboro Health Disparities Collaborative. And like TC mentioned, I'm here to tell you about a couple of studies that we've conducted over the past 10 or 15 years that help us eliminate racial disparities in the cancer care completion rate for breast cancer between Black women and white women. So as TC mentioned in his background, Our group, the Greensboro Health Disparities Collaborative, is community-based. It's community-focused, and that community focus and community-based partners with academic institutions as well as healthcare systems to identify racial health disparities and then develop strategies to eliminate those racial health disparities as well. So small groups are really important to everything that we do. We have a group meeting every month at the Greensboro Health Disparities Collaborative meeting, where we learn more from our community members and clinicians and academics about what are we struggling with in our community in terms of racial equity in healthcare. From those discussions, we can develop grant writing teams to formalize our studies, and then partner with our institutions to actually conduct those studies. And then eventually we seek out NIH funding to support those studies in a more formalized way. So as TC mentioned, I wanted to tell you about the Cancer Care and Racial Equity Study. This is what we internally refer to as CCARES. And it started with a simple question. Among patients who delayed or discontinued their breast cancer care, and are those factors that cause Black women and white women to discontinue care the same? So are there racial disparities in why people continue or discontinue their care? So we examined our local registry for cancer between the years of 2001 and 2002, and then selected a group of people to follow up with so that we can learn about their experiences in our healthcare system. From that, we learned that there are shortcomings in our cancer registry in and of itself. So our database was not complete, and that created a barrier to understand why people left their care or stopped their care or continued. And then through what we call critical incident techniques, which include community-based conversations and focus groups, we learned about other important differences in our patients' experiences depending on who they are by their race. So from CCARES, we learned and got funding through a couple of different organizations to help support some of our work. The Lance Armstrong Institution. We partnered with our local healthcare institutions, and by local, I mean Cone Health in Greensboro, as well as UNC Chapel Hill, University of North Carolina at Chapel Hill, University of Pittsburgh at UPMC, to do our follow-up conversations with our patients involved in this retrospective study, and then to learn how to disseminate the results of our CCARE study. So this allowed us, through CCARES, to apply for NIH funding to support an accountability for cancer care through undoing racism and equity study. So this is the ACURE study, a direct follow-up to what we learned from our local community, our healthcare system, and our academics about those patients' experiences and why they discontinued their care or continued their care in breast cancer. And so we've published this study at this point in time. It's published in the Journal of National Medical Association, where we actually disseminate our results. And I'm going to describe what those results are right now. But the first thing I wanted to take a step back and mention that this study is supported by Cone Health in Greensboro, the University of North Carolina at Chapel Hill, the partnership project with TC described a little while ago, and Sisters Network, and as well as UPMC, University of Pittsburgh Medical Center. So what is the ACURE study? So the ACURE study seeks to understand and formalize those things that we've just learned about in the CCARES study, right? And so why do people leave the study, leave their breast cancer treatment, and why do people continue? This required us to develop a new real-time registry from the electronic health records of our patients to better track and identify patients in need and patients who are missing their appointments, and to understand why. We also include a nurse navigator. This is a liaison between patient and clinical team to help understand and bridge that gap in communication between our patients and our oncology team, our clinical team. And then we develop a system through our real-time registry to also get clinical feedback about our patients' experiences as they're going through their treatment. So our study has two components: a transparency component. This is what we promise to our patients, to treat them well, to follow up with them, to make sure that they are not falling through the cracks of our system. We have racial equity healthcare training sessions where we help our clinical team become up to date with racial equity and implementing racial equity in their healthcare practices. We have an accountability component where we actually monitor what's going on with our patients, making sure that they are receiving the care that they need. And then, as I mentioned, we have a navigator, a care navigator that helps bridge the gap in communication between patient and clinician. So to summarize our results, in our retrospective study, this is pre-CCARES, pre-ACURE, we found a racial disparity between where 79% of Black patients will complete their therapy, while 87% of white patients will. In our concurrent group, in our study design, that number improved to 83% for Black patients and 90% for white patients. But in our intervention group, this is a group that received full ACURE interventions, that racial disparity was completely eliminated, where 88% of Black patients and 89% of white patients completed their care. So in conclusion, our real-time registry combined with feedback and navigation improved completion rates for all breast and lung cancer patients to narrow the disparity. And so just to kind of summarize what we've learned through our CCARES, when starting with CCARES all the way through our ACURE study, is that among patients who delayed or discontinued their breast cancer, there were factors that reported by people that indicated that African-American women had different completion rates than white women. Through our ACURE intervention set, we were able to eliminate those racial disparities in cancer treatment completion rates between Black and white patients. Where we are today, we're disseminating our work and learning how to disseminate most effectively. We are publishing and trying to publish in prominent medical journals, which we've done so far, conducting racial equity trainings to help other healthcare systems and even those within our own local area learn how to include racial equity in their therapy and their treatments. And we are also conducting workshops and trainings to help disseminate this work further. So with that, I would like to close out and thank you all for your time.